Hello, everyone. Today's topic is about appendicitis. Since we are covering the surgery, and appendicitis is one of the most commonly asked topic in surgery. By the way, my name is Dr. Muhammad Nasir Jola. Let's jump right into it. What is appendicitis? Appendicitis, I think it's self-explanatory. The definition is inflammation of appendix. Or in another word, we can say appendix distension or ischemia following luminal obstruction by what? When the appendix luminal get obstructed by feculate. What is feculate? Feculate, it looks like this. It is hardened feces that forms stone. So luminal obstruction by feculate, by parasites, by foreign body, by neoplasm, luminal obstruction by fibrosis, and also by ischemia. And also, luminal obstruction could happen by infection that initiate hyperplasia of lymphoid follicles. So look at this picture. I will get back to it in a second. So appendicitis, if we just revise it quickly, inflammation of the appendix or appendix distension and ischemia following luminal obstruction by feculate, parasite, foreign body, neoplasm, fibrosis, ischemia, infection that initiate hyperplasia of lymphoid follicles. So if you see in the picture, you will see an appendicitis. But on the right side, inside the circle, you can see a bigger picture of the appendix, that how the inflammation happened. Actually, the feculate blocked the luminal and it caused appendicitis. So acute appendicitis, in terms of epidemiology, 6% acute appendicitis happens in 6% of population. Male are more affected than female. 80% happen in a young age between 5 to 35. Pathogenesis. When the luminal obstruction happens, bacterial overgrowth happens, inflammation and swelling happens, increased pressure happens, and then localized ischemia, which leads to gangrene and perforation. When perforation happens, either localized abscess or peritonitis happens. So this is the whole pathogenesis of appendicitis. In terms of etiology, children or young adult, the etiology is mostly hyperplasia of lymphoid follicles initiated by infection. It's very common. Adults, the etiology could be different: fibrosis, structure, feculate, obstruction by neoplasm, or other cause could be parasites, foreign body, and so on and so forth. So as I mentioned before, in terms of epidemiology, male are affected twice as female. Okay, let's talk about the signs and symptoms of appendicitis. It's very, very important. Abdominal pain is the first symptom. Remember, it might be in the case. It usually starts around the umbilical, and it localizes to the right lower quadrant. It would follow by anorexia, nausea, and vomiting. Usually temperature would be 38 or lower than that. If it is more than 38, usually there's a high chance of perforation. The most reliable feature is progression of sign and symptom. Just to mention abdominal pain, you might get a case that what is the most common and first symptom that happens in appendicitis? Remember, it's abdominal pain. It could be a case. Okay, then we have some specific or spatial sign when it comes to appendicitis, like McBurney sign. McBurney sign is positive in inferior appendicitis or appendix. Schwartz sign, it usually positive in retrocecal appendix and Schwartz abscess. Obturator sign is usually positive in pelvic appendix. In pelvic appendix, the obturator sign would be positive. We have another special sign that's called Rothschild sign. Rothschild sign, when you palpate the left lower quadrant and the tenderness is present on the right side, it could be positive in acute appendicitis as well. So these special signs could help you with diagnose. But when it comes to diagnose, we have to have a combination of clinical presentation, like somebody complaining from abdominal pain that started from umbilical area and localized to lower right lower quadrant, nausea, vomiting, and all these clinical signs and symptoms are plus blood work and imaging. So in blood work, very important. I will get into it in a few seconds. After blood work, you need to do some imaging, especially ultrasound, the first best imaging, and then CT scan and MRI comes after. CT scan is the best confirmatory. So basically for diagnosis, you need them all. So when it comes to blood work and urine analysis, obviously we do the lab work after the ABC. So you start the IV line, normal saline bolus. So then you do the CBC, blood work, blood group, electrolytes, creatinine, LFT, INR, and PTT, beta HCG, urine analysis. So one of my students, usually when I was teaching appendicite, he used to ask me like, why creatine? Why do we check creatinine? Because we are using antibiotic and other medication, we have to make sure that these medications are toxin and there is a way to extract them, especially the toxin. LFT, why LFT anesthetic? Because you know how the anesthetic used, so we have to make sure the liver is working properly because we are using the anesthetic and also beta HCG to rule out the ectopic pregnancy. When it comes to imaging, so three most important thing to remember. The first best initial, or we can say the first best or the best initial, is ultrasound. It is the best choice to rule out the gynae pathology, best choice for pregnant, best choice for children, can rule in but cannot rule out. And overall, the accuracy is 90 to 94%, but if it is more than 6 mm, sensitivity and specificity increases to 98%. CT scan is the best confirmatory choice. It's the best choice confirmatory, but it's not used for pregnancy, pregnant patient or children. When it comes to MRI, it's controversial, but it can be used for children, it can be used for pregnant, but the preferred imaging is ultrasound for pregnant and children. For the treatment, admit the acute appendicitis for emergency surgery. Admit subacute appendicitis. What is subacute? When the patient has more than 5 days of symptom. So you give them antibiotic plus minus percutaneous drainage of the abscess, NPO, metronidazole, cefazolin for the 24-hour, if not perforated. But if it is perforated, then you give them the second and third generation cephalosporin plus fluoroquinolone plus metronidazole if it is perforated. Then we have another term called interval appendectomy. What is that? So if the patient is stable and has appendiceal abscess, you give him IV antibiotic, bowel rest, and possibly percutaneous drainage. And 6 to 8 weeks later, do the appendectomy. This is called interval appendectomy. Morphine preoperative started 2 to 10 milligram IV subcutaneous, repeated every 2 hours, PRN. Follow up with family doctor in 2 weeks which is very important, and also follow up with a general surgeon within 4 to 6 weeks. Very, very important. You might get a case to ask you about the follow-up. So these are the pictures about the uncomplicated and complicated appendicitis. In terms of treatment, I have a few notes to share with you guys. So the first thing is most patients with acute appendicitis seek medical attention in the first 24 hours, 24 to 48 hours to be exact. Another note, risk of infection and intra-abdominal abscess are higher in laparoscopic appendectomy than laparotomy. So let's say a few days after laparoscopic appendectomy, the patient comes or presents with recurrent fever. Let's say you did the laparoscopy appendectomy, your patient after a few days after that came back with a recurrent fever, abdominal pain, and vomiting. If you have a case like this, it is most likely that it is intra-abdominal abscess. Intra-abdominal abscess. There's another short note about the mortality rate. 0.08% in non-perforated appendicitis, 0.5% in perforated appendicitis. So mortality is high in perforated appendicitis. Let's talk about surgery. So as I mentioned before, we have two types of surgery, laparoscopic, laparotomy. In laparoscopic laparotomy, it is mostly done or used for acute appendicitis, mostly for pregnant patient with appendicitis. It's a good choice, cause less pain and less scarring. High chance of infection and intra-abdominal abscess comparing to laparotomy. So when it comes to laparotomy, so it's an open surgery. Obviously, it is mostly used for perforated appendicitis or complicated appendicitis. Obviously, it's open, so more pain, more scar than laparoscopic appendectomy. Okay, recent research supports antibiotic-only treatment as a reasonable for uncomplicated appendicitis, but the recurrency is 10 to 20%. Remember colonoscopy, if somebody who has appendicitis and the age is more than 50, do a colonoscopy to rule out another other malignancy or etiology like neoplasm. Okay, appendicitis during pregnancy. This is very interesting. Just want to mention a few things, probably 3 or more. Very important. The pain. Patient may have flank pain or right upper quadrant pain or right middle quadrant pain instead of right lower quadrant pain. Same approach is the same as non-pregnant, but remember you can use ultrasound, not CT scan. Best and confirmatory imaging is ultrasound. So remember the pregnant patient, if she present with appendicitis, the pain might not be in the right lower quadrant. It might be upper, flank, or right upper middle quadrant pain. So let's do some questions. A 25-year-old married female complains of abdominal pain that started from around the belly button, from umbilical area. In the last 2 hours, the pain localized to the right lower quadrant. So very typical picture of appendicitis. Now she has anorexia, nausea, vomiting. So what is your diagnosis? Acute cholecystitis? Probably not. Acute appendicitis? Most likely. Ectopic pregnancy? Probably not. Ovarian torsion? Probably not. Why not acute cholecystitis? So let's see the keyword. Pain that started around the belly, localized to right lower quadrant. Acute cholecystitis, the pain is more in the right upper quadrant, and the pain radiates to the right shoulder. So this is out. Acute appendicitis is the correct answer. Ectopic pregnancy, the patient has no vaginal bleeding and there is no history of missing menstruation. Ovarian torsion, mostly it happens after intense workout or physical activity or sex, and plus presence of adnexal mass, which we don't have it in this scenario. So let's do another case. How about we have the same scenario, but we change the question. A 25-year-old married female complains of abdominal pain that started from around the belly button, but in the last 2 hours localized to the right lower quadrant. Now she has anorexia, nausea, and vomiting. Very typical picture of appendicitis. Now it says the question is, what are the diagnostic options for this patient? What are the diagnostic options? Clinical options, blood work options, imaging options, all of the above. Obviously, all of them. So the keyword is what? Abdominal pain that started around the belly in the last 2 hours, localized to the right lower quadrant, nausea, vomiting. The correct answer is all of the above. We need to do the clinical, blood work, and the imaging. Okay, how about we do the same scenario but change the question? A 25-year-old married female complains of abdominal pain that started from around the belly button, but in the last 2 hours localized to the right lower quadrant. Now she has anorexia, nausea, vomiting as well. After proper clinical blood work and imaging, your diagnosis is acute appendicitis. So what is the best next step? So if you have the diagnosis, how do you treat it? Antibiotic and discharge, painkiller and discharge, right away laparotomy and in less than 30 minutes, IV hydration plus IV antibiotic plus surgery in less than 12 hours. Antibiotic discharge is dangerous action. There's a high chance of perforation after 24 hours. Painkiller discharge, same thing, dangerous action. Right away laparotomy is too early, and the patient needs preoperative antibiotic and hydration. This is the correct answer. Hydration, IV antibiotic, and do the surgery in less than 12 hours. Thank you very much for watching this informative and educational video, which is prepared by me, prepared and posted by me, Dr. Muhammad Nasiri Jala. I'm the president and the CEO of Jala Academy. And in Jala Academy, we have a very good slogan that it goes like, feel your professional pulse here. We use reliable sources like Toronto Knows and Uword Usmele in these videos. Toronto Knows from Canada and Uword Usmele from US.